Great. Well, hello. I'm Bob Harrington from Weill Cornell Medicine in New York City, and I'm delighted to be joined on this live event by my colleagues, Dr. Jeff Barnes at the University of Michigan and Dr. Roxana Mehran from Mount Sinai in New York City. Jeff and Roxana, it's great to be with you again since we last talked on this topic at the American Heart Association meetings in Chicago. There we had a great, fun, live in-person event. Roxana, I do have to give you the tip of the hat since your team, the Thrombosis Titans, walked away victorious in that particular show. I also want to welcome today our audience joining across multiple and different social media platforms. Today, we want to take a deeper dive into some of the key points that we were discussing at the symposia, particularly the emerging role of factor XI inhibition in the management of patients with suspected thrombotic disorders. It's an exciting topic. Please send in your questions and comments. And maybe I'll start, Roxana, with you. Why don't you give us an answer to the question, why do we need more anticoagulants? And why is there such intense interest in the factor XI inhibitors?
It's such a good question, Bob, right? I mean, I think the idea of yet another anticoagulant to add to the multitudes of choices that we clinicians have at the moment with regard to the type, to the patient presentation, to the duration, and all of the multitudes of the combination therapies that we are implementing in our patients. One asks and begs that question, why another anticoagulant? The truth is that our patients are becoming much more complex. Mm-hmm. We're seeing that every single day, a patient that comes in who has very, very high ischemic burden with high risk for ischemic events, yet they're also at very high risk for bleeding complications. Mm-hmm. And that overlap is what absolutely puts us in such a dilemma in choosing. How do we choose? For how long? In whom? How do we make the best plan for our patients to give them the best ischemic benefit protection without harming them, with exposing them to extra bleeding? Because we know once they bleed, then ischemic events come forward. So this uncoupling of ischemic and bleeding complications, hemostasis and thrombosis, is of utmost importance, and where maybe factor XI, another new novel anticoagulant, can actually make that happen.
Roxana, perfect setup for Jeff. Jeff, why don't you share with the audience, from your perspective of somebody who sees a lot of patients with thrombotic disorders, how do we think about this decoupling of thrombosis from hemostasis? Two things that people have long sought, but no one has really found yet.
You know, Roxana really set this up nicely. And at the risk of triggering our audience from their days in medical school or nursing school or pharmacy school, you have to go back and remember the coagulation cascade. And I think this image here that you're seeing really helps to explain why we think we could decouple hemostasis, or the prevention of bleeding, from the prevention of thrombosis, the pathologic clot that causes a stroke or something like that. And we remember there's these two arms. They're represented on this image as a blue arm, our tissue factor or extrinsic pathway, and then the pink arm, our intrinsic or contact pathway. And most of our current anticoagulants either target both arms together or where they come together at the same point, that green common pathway. And so what happens is we end up preventing both of these from occurring. Yes, we prevent that thrombotic event, the heart attack, the stroke, the blood clot in the lung, but we also prevent the body from plugging up a small damage to a blood vessel that could cause bleeding or bruising complications, the hemostasis effect. So if we can instead target just that pink pathway, that intrinsic or contact pathway, we could potentially prevent the thrombus from forming, prevent the heart attack, prevent the stroke, prevent the blood clot in the lung, but allow the body to achieve hemostasis, plug up those small damages to blood vessels so that we don't bleed out, so that we don't have bruising. And factor XI is right there in that intrinsic or contact pathway, and it's also really central in this thrombin feedback or thrombin amplification loop, where when you start to build some thrombin, it says, oh, I must need more clot to form, so it starts feeding back on itself. And that's how we get these big clots forming. So if we can break that, we can hopefully prevent a clot, but also allow the body to plug up those holes so that we don't cause bleeding.
Incredibly important when we think about taking care of the patient with a variety of vascular diseases, with invasive procedures, et cetera. So thanks for walking us through that. Jeff, already we're seeing questions come in from the audience. Somebody wants to know, tell us how factor 11 inhibitors are different from the factor 10 inhibitors and maybe other factor 2A inhibitors, the other DOACs.
Yeah, it's a great question. And I would say there's two main differences. Obviously the target, right? And that's what we just looked at on that last slide. But also now we're looking at different mechanisms by which they act. So all of our direct oral anticoagulants, the ones that target factor 10A and the direct thrombin inhibitors, they're all small molecules, which means that they're orally available, they have rapid onset and fairly rapid offset. So you have to dose them once or twice a day. But with these factor 11 or 11A inhibitors, we now have multiple ways that we can inhibit this. You can use an antisense oligonucleotide, essentially shutting down production of factor 11 in the liver. That's going to require a long time to start up, but then it's going to last for many weeks, right? You could also take a monoclonal antibody and bind up to factor 11 and prevent it from doing its job. That would be a much more rapid onset, but it also could last for days to weeks. And then, of course, we have the mechanism we're most familiar with, those small molecules, an orally available agent. You're going to dose that once or twice a day. So there's different ways in which we can approach this, a lot more options.
Well, let's go, because there's actually, in addition to talking about mechanism, there's actually some data that's starting to be collected. So why don't we take a look at what are the trials that are underway, and maybe I'll give some overview here, and I'll turn to the two of you for any added help. First off, I hope our audience realizes that this is an exciting area for investigation. We see a variety of agents, as Jeff has described, different mechanisms, different things that you might think about when using the therapies in a variety of clinical trial settings. All of these are associated with increased thrombotic risk. So total knee replacement, we know that this is a long-standing place where antithrombotic agents have first been studied. It's a great model of human clot. Acute myocardial infarction, and this largely refers to the post-myocardial infarction period of time, not necessarily upfront. Atrial fibrillation, an area where the factor 10 inhibitors, the factor 2 inhibitors have made huge inroads and have really transitioned us from a vitamin K antagonist perspective to the novel and the direct acting oral anticoagulants. Stroke, an area where we have limited therapies for the patients who suffer stroke, particularly in preventing a second stroke. Cancer, I know you see these patients, Jeff. I see less of them. Roxana sees less of them. But here's an area where we have a true unmet need of thrombosis associated with various cancers. A tough area that I know Roxana's worked in, the end-stage renal disease population and their thrombotic risks. So maybe, Jeff, I'll start with you. Do you want to just help the audience understand sort of the broadness of what we're doing here?
Yeah, I think this is such a great and important point, that these drugs are being tested across so many different therapeutic areas, right? These different areas in which patients experience thrombosis risk. And we also have many of these patients who are at very high bleeding risk, exactly where Roxana started us out. And that's where the unmet need is, right? That's where we need to see if we can help to prevent thrombosis. And what I think was most telling for me as I looked across all of those phase 2 studies was that there really was not an increased risk of bleeding when you use these different factor 11 and 11A inhibitors. And importantly, we didn't see that dose response curve for bleeding. So whether you use small doses or large doses, we saw very low rates of bleeding, actually lower than what we saw with some of our other active comparators. So an enoxaparin or a direct oral anticoagulant, sometimes even on par with what you saw with placebo. So they seem to be very safe. The question really is around efficacy, and you start to get a hint of that in those phase 2 studies. In fact, if you look at those total knee replacement surgeries, we start to see that dose response curve where you get to the higher doses, you prevent thrombosis from occurring, and so there's a lot of reason to think that there's promise coming out of those phase 2 studies. but it's really going to be the phase 3s where we get some really robust efficacy data.
You know, Bob, when I look at this incredible view of the different clinical scenarios that this therapeutics might actually work, I'm struck by the cancer, the end-stage renal disease patients. By the way, they're also at very high risk for stroke and atrial fibrillation. And so when you think about how these patients are intertwined in these different clinical programs, where we really have a very, very difficult time separating ischemic and bleeding risk, it's where we have very little data with the current oral anticoagulants working well in these scenarios. And then in the total knee replacement studies, I think to me is incredibly important for the phase 2 that Jeff just showed, that is telling us that this could be a way to better understand some of the early safety and dose finding studies that might be seminal to starting these phase 3 programs. So again, really, really important to see how this entire field is evaluating these drugs prospectively.
Yeah, to me, who's someone, well, actually all three of us have been involved in these fields for quite a long period of time. The fact that you can prevent clot in the knee replacement patient is a really important step, is that we know that you can affect human thrombosis, and that's different than just being able to do it in the preclinical models. And as Jeff is pointing out, this lack of relationship between bleeding risk and dose or potency, I think, is pretty important. We've not seen this with other agents, and so this is a pretty important observation. Well, one of the questions that arises is, do we have any phase 3 data yet? And maybe we can look at that OCEANIC study, and Roxana, and have you and I and Jeff walk through this, because there has been a study of one of the factor 11 inhibitors, asundexian, in atrial fibrillation, which was actually stopped early by the DSMB, not just because of lack of efficacy, but because it really looked worse from an efficacy perspective than did apixaban with regard to stroke prevention. Roxana, you want to lead through an early conversation here and tell us why this is important?
You know, the stopping of this trial was really shocking to me, and then watching the presentation at the European Society of Cardiology and then be published in the New England Journal of Medicine really showed us what really happened, because what we saw is the separation of the curves almost effective immediately post-randomization in showing no clear benefit of asundexian at that dose given to the patients with atrial fibrillation. And so you have to be thinking, was this the right dose? Was this the right dose in these patients? Was it potent enough? And I think that was really, to me, was a very, very big takeaway. And of course, the lack of not understanding, this was the one program where we didn't see the total knee replacement data in the way that in that particular scenario of to better understand the safety and efficacy as we have done in other programs. Was that a misstep? I really don't know, but it sort of begs the question. And I'm sure there are other topics that you guys want to probably talk about.
Yeah, no, I think for me, that really begs the question, right, is that we didn't have any real solid human data that clot could be prevented. We had some data that bleeding was going to likely be less, but we didn't really have that total knee or total hip replacement data that's proven to be so critical in earlier studies with other agents. Jeff, your view of OCEANIC-AF, and tell us, Jeff, why you remain excited for AF studies still to be underway despite these results.
Yeah, I think that I, like so many others, was so disappointed when about a year ago we heard this trial was stopped. And looking at the data really helps us understand why. That graph we see on the left with, you know, a more than threefold increase in the risk of stroke or systemic embolism for the asundexian arm compared to the apixaban arm, However, I think there was some good news that came out of the trial. If you look on the right side, safety was confirmed, right? The asundexian arm had a very low rate of major bleeding, even lower than what we would see with apixaban. And we all think apixaban is a pretty safe drug to use in a large portion of our patients with AFib. And so it does raise that question. If we could get a different dose, might we actually see some more efficacy while maintaining safety? Certainly the phase 2 studies would suggest that could be possible. The other reason I remain highly optimistic is that there are several other phase 3 studies that are ongoing, and many of them have already passed their first DSMB checkpoints and said, yes, you can continue the study. So they're not getting shut down early as well. So that tells me that there's at least a good chance that we're going to see some promising data come out in the future. Certainly the phase 2 studies, especially those total knee replacement studies, suggested that if you get the dose right, you could actually prevent thrombosis from occurring. We'll have to see whether a post-operative venous thrombosis prevention study translates into an arterial study, which is what we're seeing in many of these drugs. You just look here on the screen, you see, 3 different drugs using 2 different mechanisms. The first is abelacimab, a monoclonal antibody being used both in an atrial fibrillation population in people who the clinician says, gosh, I don't really think you're suitable for anticoagulants, probably because of bleeding risk. Maybe a factor 11A could help to prevent thrombosis without increasing bleeding. Very interesting study to test. And then 2 cancer-associated VTE studies, one in all comers and one in GI and GU patients. Very high thrombotic risk and high bleeding risk. And then we've got the 2 other drugs, asundexian and milvexian. Both are small molecules, so you're going to take them once or twice a day. And they're being tested in a couple places. We've got a secondary stroke prevention study going on. We've got an AFib study going on. And we've got an acute coronary syndrome study going on. So we've got 4 studies that are still going on using these 2 agents. So really, there's a lot still to learn. And I think the next 12 to 24 months is going to be really exciting as we start to get some of these results out.
Well, that's a terrific overview, Roxana. I want to go back to you with one specific question. You and I are both involved with the milvexian studies, including the ACS study, where patients will undoubtedly be undergoing procedures while on milvexian. Some interesting phase 2 data with abelacimab that shows that, hey, maybe you don't have to worry about doing invasive procedures while on these drugs. You want to comment on that?
Yeah, I mean, I was really floored almost by the data from abelacimab that was presented by our colleagues at the Brigham, and they showed, the monoclonal antibody, it lasts for about a month or so, and these patients had procedures, surgical procedures, and there is no antidote at this time, and so they have active drug. And they went through these procedures with no issues at all. And this really begs the question that there must be a mechanism by which there is an uncoupling of thrombosis and hemostasis in these patients, which is really, it's the biggest question. What do we do with our drugs when the patients undergo procedures? It happens on a daily basis, and we really have to figure that out.
Yeah, this is going to be a key issue, whether or not you're on the short-acting small molecules where you might be able to stop and hold it, or you're on the longer-acting drugs. And part of that is going to tie into this next thing I want to get to, which is the patient journey, is that it may well be that there'll be different drugs, different mechanisms for different parts of that patient journey. So why don't we look at this, and maybe you can kick us off, Jeff, as to how you see the factor 11 inhibitors fitting into some of these key parts of the patient journey. And then I'll ask Roxana, particularly to weigh in on the risk of bleeding piece.
Yeah, I think there are several areas in which our current oral anticoagulants are very limited. Right now, you have to take a DOAC or a vitamin K antagonist every day, maybe twice a day. That leads to some concerns with adherence and persistence. Patients sometimes forget to take a medication. Sometimes they aren't able to stick with it. What if you could take a drug once every week, once every month, right? There's a lot of potential benefits there to help with persistence and adherence. We know that drug-drug interactions can lead to lots of adverse events, either bleeding or thrombotic. If you can reduce those, and certainly if you can eliminate some of the renal clearance issues for our end-stage renal disease patients, you can then open up these therapies to many more patients and potentially make them safer. So there's a lot of opportunities to fill some really critical gaps there.
I mean, I think the idea that these factor 11 inhibitors have some or no renal or hepatic clearance or metabolism is very, very attractive, especially for these high-risk patients. Given, you know, if you think about cancer patients, those patients with end-stage renal disease, but all of this comes back to me, maybe because I'm so interested in this arena of the bleeding. The risk of bleeding can't be underestimated. These patients who have bleeding have higher hospitalization rates, and by the way, they end up with more ischemic events. And what I'm really floored by from all of the data that I have seen is the fact that we are not seeing an increased risk of bleeding. Do you know, this is the first time when you're adding a potent agent in which you're not getting increased risk of bleeding that we would have observed in pretty much every other combination that we have done to date. And to me, this is what's novel about these therapies and makes this patient journey a much more enjoyable ride for them without having to worry about trauma or surgical procedures or other things that exposes them to important bleeding risk.
You know, building on that, Roxana, is I think all of us are well aware that the DOAC success in part has been to the fact that they improve the efficacy of oral vitamin K antagonism in, say, stroke prevention with AF, while also having favorable bleeding profiles. But this is really the next step, which is that can we see agents which are as good as the factor 10 inhibitors, or in the parlance of a non-inferiority trial, you know, no worse than, and with regard to stroke prevention, and can we see less bleeding? Remember, in non-inferiority, if you're going to make an exchange for the non-inferior product, you better get something in return. And in this case, what we're looking for in return is less bleeding. So that's pretty exciting.
Bob, I also think it's important to remember that many of the populations that are being studied in these factor 11 trials are populations that were explicitly excluded when the direct oral anticoagulants, the factor 10A and factor 2A trials, were being conducted, because we didn't want to enroll that high bleeding risk patient, that cancer patient, that patient with end-stage renal disease, for good reason. But that means that those patients currently don't have high quality phase 3 level data to support the use of an oral or an injectable agent for them. In these trials, we're finally going to get that data. And with this potential of decoupling thrombosis prevention from allowing hemostasis to persist, it may hit the sweet spot for some of those really needy, vulnerable groups that are really aching for some high quality therapies.
Yeah, and I think that having such a set of choices across the different mechanisms also lends itself well to that this is not all just about small molecule inhibitors, though while very important, it also opens up an avenue for more long-lasting therapies that might be particularly helpful for certain groups of patients. Why don't we go to the next slide, which sort of summarizes where we're at in all of this, and then I've got a couple of questions from the audience that I'd like to ask you. Sure. If we could go to our final slide. So what have we learned? Roxana, you want to kick us off?
Well, no question that, you know, this is an unmet need. Understanding that we've got to be thinking about bleeding as well as thrombosis, and how we could absolutely expand the indications to those who are at very, very high bleeding risk, in which we are being very, very cautious and perhaps rationing the care of these patients by not giving them what they absolutely need against their thrombotic risk. So to me, that's a very, very important part.
Jeff, you want to take the next one?
Yeah, I think this is really such a critical factor. Can we better balance that risk reduction for thrombosis against the risk of bleeding? And can we find a place where we can prevent thrombosis without increasing bleeding? Not just in those populations where we're currently not treating them, but even in the populations where we are and it's risky, right? I'm thinking about the AFib patient. I'm thinking about the VTE patient where we use an anticoagulant and we just kind of hope, we cross our fingers that they won't have bleeding complications. Will this open up a new therapeutic class that allows us perhaps some better balance between those two?
Yeah, and I'll sort of combine the next few things, which is that we've seen different agents may benefit different groups of patients, and both of you have walked through this in a very eloquent way. And from my overall perspective as a clinician and as a clinician researcher, this is a really exciting and promising target. It's a whole new area of biology. This decoupling of hemostasis and thrombosis, if it's real, might turn into better therapeutic approaches. This is fantastic hypothesis, but not surprising, more research is needed. For those of you who have listened to our discussion over the last half hour, please scan the QR code to claim your CME credit. And I want to now maybe turn to a question or two that I have from our audience. So, Jeff, I think getting into specific areas of interesting patient treatment, this will probably be something for you. Somebody's asked about the role of anticoagulation therapy in burn patients.
Ooh.
Is this something that you see in your practice?
Yeah, I don't. We have a dedicated burn unit and they see folks down there, but I do know that that is an area, because those patients have a lot of inflammation going on. They're also not very mobile. If you have significant burns, there is a high risk of thrombosis. As you can imagine, these patients are also at very high risk of bleeding, both from the burn sites and the surgeries that are used to treat them. And so it's another area in which finding a drug that could better balance thrombosis prevention from not causing bleeding could have some potential impact. I would see that as maybe a stage 2 or stage 3 area to explore, but certainly a great question.
Yeah, it's a great question. And it also plays into this area of different mechanism of action over different periods of time might be beneficial. So you might think about a parenteral agent at some point during that patient's journey from recovering from significant burn, and then transitioning to small molecule inhibitors, perhaps as oral therapy can be instituted, et cetera. So it's a really insightful question, and it plays well to factor 11.
And I want to just add to it, because you brought up a great point. Anytime you have a patient in whom you know there are going to be upcoming surgical procedures, it becomes critical for us to know how safe is it to perform that surgery either on the anticoagulant, or do we need some regimen to sort of stop it? And that's where the data that Roxana mentioned earlier, using abelacimab in their AFib phase 2 study, was really exciting to say, perhaps you can do surgery while patients are fully treated with an anti-11 and 11A agent. We're going to need more data from more agents and more surgeries to really understand that better, but that's going to be a real game changer if it's shown to be replicated.
You know, I think about the areas like those patients who are in our intensive care units. They never get into clinical trials. We never get to understand, but imagining that in this kind of a therapy could be used in those patients, the shock patients, or even those waiting transplantation with bridge therapies with LVADs. They are very immobile. They have a lot of risk of thrombosis, and of course the idea of having therapies like this perhaps studied in those patients are also really, really important once we pass this hurdle to actually show and prove that this concept is real.
Well, you both answered parts of that last question that we had, which is somebody's asking about how do you deal with this whole notion of enoxaparin 12 hours before an operation. It gets right into what you said, Jeff. Well, maybe we don't have to worry about stopping agents, thinking differently about agents. You can imagine a whole variety of clinical settings that Roxana's starting to bring up, where having more control over your ability to do procedures while remaining anticoagulated will be pretty critical. Jeff, maybe in the last moments, just comment on what we know about factor 11 deficient patients, where we've also learned some of these things about bleeding risk.
Yeah, it's amazing. There are many patients who have factor 11 deficiency, but don't know it or don't present until later in life because they don't have bleeding complications. You know, when we think of a patient who has hemophilia, we tend to think of them as presenting young in life because they have these bleeding issues, bleeding in joints, other things like that. But for our factor 11 deficient patients, they often don't have those bleeding complications. Yet some epidemiologic studies have shown they also tend to not have heart attacks, strokes, and blood clots in their legs or lungs. And so that's really a lot of the reason why we think we might be able to target this, this particular part of the coagulation cascade and get the benefit without having the risk of bleeding.
Well, you both have been terrific. I want to thank you both. This has been a fast-packed 30 minutes, but hopefully great information for our listening audience. Please do scan the QR code that you had seen for participation as a CME activity. I want to thank my colleagues, Dr. Roxana Mehran from Mount Sinai in New York City and Dr. Geoff Barnes from University of Michigan in Ann Arbor, Michigan. Thank you both for joining, and I suspect we'll have a lot of opportunity to discuss these therapeutics in the future.
Thank you, Bob.
Thanks,
Happy
Bob.
holidays to all.
Thank you.